Lewin. I'm a physician with a kind of an eclectic career. I've seen healthcare from every angle. On hospital systems, been a physician in many capacities as an internist and through cardiology, but also a very large part of my career was public health. So Georges, it was great to see you here in your leadership. We've known each other for over 30 years, basically. Back to the days when I was director of health in Hawaii, and we had that heady, got universal access for most of the people of the state. It was incredible. Indian Health Service commissioned officer and so forth. So, you know, recently, I guess for the past, what, John, it's been 7, 8 years, I guess, where I've been on the board for National Coalition on Healthcare for quite a while, been the chair for, I think, 6 years or 7 years. And it's really been an honor and a privilege. Today, we're going to get into some interesting topics and discussions. We've already had a great discussion today, and it's been fascinating. But I'd like to introduce our panelists, and then I'll make a couple of remarks just as an opening of the session. And Frederick Cerise is the CEO and president of the Parkland Health and Hospital System in Dallas, a very famous institution, obviously, and that's a great job. He's also the commissioner of the Medicaid and CHIP Payment Access Commission, MACPAC. So very fitting role for today. Susie Distefano is actually, we're getting the order a little bit. Susie's on the far left side, or your far right. She's the CEO of the Children's Memorial Hermann Hospital in Houston. And it's a very significant center, so also a wonderful vantage point for today's discussion. And then Jamie in the middle, Dudensing, is the Chief Executive Officer of the Texas Association of Health Plans. And as such, you know, that's both public and private health plans, but also improving access to quality and obviously affordability and all the issues that we're trying to talk about today. So it's really going to be a delight to have this discussion coming up. So I wanted to just sort of start this off because, I mean, I heard a lot of really interesting things about children's health care today. We didn't talk much about the mental health issues with children, which are incredibly complex, and particularly some of the privacy issues and, you know, exchange of the work that has to go on in that area. But we can maybe talk a little bit about that later. But I wanted to start off by just reminding us that as we talk about with the National Coalition's focus on affordability, trying to promote access and quality, but somehow to make sure that government and businesses and individuals, families can afford health care, that we might want to note that this is an amazing time in which we live. Science is on a roll. And you know, in the cardiology space, where I've looked back to when I was in medical school for a myocardial infarction, the treatment was bed rest, oxygen, and morphine. We can do a lot more today with immediately turning a heart attack into an opened coronary artery where you're actually well and go home. You didn't even need anesthesia. Amazing stuff happens. We're replacing heart valves, you know, with catheters percutaneously. So it is like a science fiction time, but you know, all that science fiction, the genetics that's coming and all the rest of it is going to cost even more money. And it would be horrible if we just developed a greater path of disparity where people with the resources were able to get all this wonderful technology and everybody else wasn't. And so we've got a lot on our plate here today, but at the same time, our worry is that healthcare is actually vampirizing all the other sectors of the economy. So we have to do something about costs. And I guess one of the bits of good news in that regard is that at 30 to 40% at least of all these costs, you know, aren't producing any health. So we have a lot of waste and a lot of opportunity to be more efficient across the entire health sector. And maybe it's hard to do, but it really does give us an opportunity to try to come up with some more resources if Congress is going to be stingy. And so that's important for us to think about. The solutions that we've talked about here are elusive. The value-based reimbursement, great idea, we're all for it. The National Coalition is a leader in promoting it. But what we've seen in the last 3 or 4 years is that even states that had a lot of capitation, HMO, managed care integrated systems and so forth are going the other direction, back to fee-for-service. Stuart Altman, my friend in Massachusetts at Brandeis, is just shocked at how rapidly Massachusetts went from a lot of organized care with new payment models back to fee-for-service. So that's happening, and we got to be careful about that. Data interoperability. I mean, you know, David Breuer, a friend of mine, was the first Office of National Coordinator of HIT in the federal government, and it's over 20 years ago that he came in and we're going to get interoperable. Everything's going to be able to talk to each other, and we are absolutely nowhere. We're exactly where David was when he started the process out, and that really hurts healthcare because it just prevents us from doing all kinds of creative things that we could be doing both in research and in the improvement of outcomes. We also have variation in healthcare, and the variation is appalling. And in the public health side, as Georges could say to us, I mean, we rank as like the 30th out of nations in the world in terms of health status, quote unquote, even though we spend twice as much. But the variation is such that if you just took the states of Utah and Minnesota and called them nations, they'd be in the top 5. So, it's really the whole country, there's a lot we could learn in terms of offering the best care, the best practices, the best prevention to people more consistently across the country. We just haven't figured that out. And prevention is obviously important. We talked about kids, where the prevention has to start, but when we think about how much we can do there, delivery system reform again. So, in the meantime, though, somebody said something about healthcare is complicated. Who knew? But anyway, nobody knew, I guess. Well, that guy didn't know. But at any rate, I think that the administration is kind of lurching toward, I don't know what, in terms of health policy. The Congress is heading in the wrong direction. Supposedly to save money, they're threatening to decrease the entitlements of not just Medicaid, which is always on the cutting block, but Medicare. Obviously, CHIP, we won a little bit of battle here for a short term here, but we worry very much about that. And the premium costs are going to go up for middle Americans, and many people will lose coverage. Great, we go back to the emergency department. Thank goodness for EMTALA, right? Because that'll be our medical home for more and more people. That's not saving any money. That is a disaster economically. So anyway, these are troubled times, and the National Coalition on Healthcare, as John outlined today so well, promoting value, protecting entitlements, trying to get the drug and pharmacy costs down, focusing on chronic disease and the highest spenders and the best targets for achieving better outcomes, and then obviously that includes the social determinants of health and team-based care, what we've talked about here, but sustainability, keeping coverage there for people, for everybody that needs it. So I asked the panel today to think on a couple things that they should maybe consider to present to you today. And the first question would be, what are the 2 or 3 most important strategies that we could consider and maybe even implement to promote affordability? And that's indirectly as access and quality as well. Secondly, what are the barriers to implementing those strategies? And then if we have a little more time, I wanted to ask them if they could think of something, just one thing or 2 things that were the innovations that are needed and possible that could be absolute game changers. And so we'll see what comes out of this very, very important panel group and well positioned to answer these questions. So let's see. Fred, why don't you want to take it off?
Sure. So the question is around what can you do to improve value? How can you, as a health system in general, I'll talk a little bit about our own system, which is Parkland, and we're in a different perspective in a lot of regards, because if you look at if you look at the way we're funded, about 45% of our patients are uninsured, another 30% are on Medicaid, and we're heavily funded by county revenues, and so we're not bound to a commercial system where you're paid for visits and you're paid for volume, but you're a more population-based approach, and really that sort of system is the type of system I think you need if you're going to stretch care across a population. If the incentives are changed from you have to do volume to get paid, you're never gonna. It's going to be hard to dampen that curve because the incentives are to do more, and
right.
And so when you look at you look at the overall health system, you see this sort of divide that's happening. We're now seeing an increase in the uninsured, for the first time since the Affordable Care Act, right? Last year it went up about 1%. On the other end of the spectrum, you're seeing this increase in concierge medicine where people are paying more to get better access. I can pay $15,000, $3,000 a year, and I can get 24/7 access, same-day appointments, that sort of thing. And then in the middle, there's the big group that is Medicare and Medicaid and employer-sponsored insurance. And that's where you see the accountable care organizations and the pressures on value-based care to try to pay for value. If you can save some money on the population, you can extract some savings. And I think somehow you've got, and so the mechanisms there are to create a continuum of care that has responsibility across the spectrum from prevention to primary care to specialty care to inpatient hospital care to post-acute care. And until you can connect those dots and coordinate those pieces and put some accountability and some ownership for the entire continuum, it's going to be hard to get your hands around cost because it's always going to bulge out someplace, right?
Yeah, right.
And so I think as you look at particularly in my setting, but in general, at the public dollar, because so much of healthcare now, it's more than 50% of the dollar in healthcare is a public dollar, or right around there. I think you have to be more intentional with how you're going to deploy that public dollar, and we can have better expectations of systems. So we can say, for instance, with in Medicaid, with the supplemental funds we pay in Medicaid, whether that's DISH or other waiver programs, let's not just pay for emergency care. Don't just send me your costs and I'll give you a percentage of costs, because what you're going to get is a lot of fragmented care, emergency care, but show me that you have a system that is providing comprehensive care and coordinated care and access for an uninsured population, for a Medicaid population. And if you do that, then we want to pay for that and we want to incentivize that. So I think we're going to have to be more intentional with the public dollars that we're spending.
Very good point. Very good point. And the barriers to that are political and maybe getting people to change.
Well, the barriers are, as you said, in healthcare, there's a lot of money in healthcare, right? And everybody's, you've got hospitals that are making money, doctors that are making money, health plans that are making money, pharmaceutical companies that are making money, device manufacturers that are making money. And so change is tough because there's a lot of separate interests that are still doing well. Yeah. And so, that's why I say you have to be more intentional with the public dollar.
A lot of middlemen.
And say this is what right. And say this is what we want to buy. We want to when we look at measures, it's not only measures of you want to look at your quality measures, but you also want to look at access measures. And are people not just getting access to care in the emergency department, but are they getting access to preventive care? Mm-hmm. Are they getting access to those people that have chronic disease? Are they getting access to good management of the chronic disease? And our payment policies right now, particularly with the public dollar, don't reflect that.
Okay, they don't. I guarantee. So from another hospital perspective, maybe we could decide, Susie, you got the children's side. What are you thinking in these regards?
So I think that you're going to hear a little bit of the same and hopefully just a slightly different perspective from the Children's Hospital. I think it's clear to all of us sitting in this room this morning that health care alone doesn't drive health status. And yet we've really been trying to improve the status of our community by kind of shoving it through the funnel of the 10% of overall health that healthcare drives. And so it's everything else around healthcare that we're trying to do a better job connecting to. So I think all the earlier comments about how do we incentivize care so that you're not paid for just your portion of the whole, but how well did you connect to that next piece of the puzzle to drive something that's longer term. It's a real challenge in a society that loves a quarterly return, and we like, hey, I want to see what's on my phone in 2 seconds, much less, wait 10 years to see, did this kid, this investment that we made in this child at birth or preconceptually drive a healthier outcome. So that, that's sort of a framework that we're going to have to shift to and get used to, and we're going to have to shift the incentives along with it. A poignant example of that today in the children's hospital world is the neonatal patient, that birth to age 1 of life uses a disproportionately higher level of everything services, dollars, and yet are we really doing a great job of taking care of that kid and getting them ready for a home that may or may not exist? Now, around my reimbursement, I'm incentivized for the most number of neonates I can get into my hospital, and to some degree, the longer they stay if they're commercially insured. We've spent a ton of time in several years now putting obstetricians in our community, maternal medicine docs out there, and it's driven down my neonatal census, so it's had a deleterious effect on my bottom line. It's the right thing to do. And happily, I've had enough support to do that so that I've been able to kind of withstand that headwind around keeping your operating margin up enough to be viable as we take some of those dollars and invest them elsewhere. But it's a perilous journey, and the calculus is tough on it, because today's incentives would suggest that I'm going to be viable and sustainable based on the right number of patients, not just volume, but the right number of really sick kids that I can get in there and keep. And yet, that's not doing anything to solve the longer term battle. So I need to be reimbursed probably and incentivized for as many kids that never come to a neonatal unit. So that's more about pop health, obviously. And then to the degree that those children do come, how do I get them to the next safe spot? 20, 30 years ago, we in an acute care setting, in a hospital setting, probably spent more time on physiologic findings and gee whiz, technology, and a lot of it very, very good, and I'm proud to be part of it. We spent a lot less around, is this child going to a home with heating? Does this child have a parent? Blah, blah, blah. Today, that's a conversation that goes very differently. Social worker is as important as the physician. The understanding around the fragility and the ACEs this child may experience in the next 3 to 4 years are part of our ownership. And how do we make sure we're connecting to that next point in that child's life? So that, I think the burden on the hospital provider is very much broadened, and it should be.
Very much so. All right. Well, so Jamie, from the insurance side, what are you thinking? Is the combination of CVS and Aetna going to save us?
It was like that was. Can you hear me? One of my favorite was it was Amazon and Berkshire Hathaway. Who's the third one?
Yeah.
I was sitting there and I was like, good luck, right?
Yeah.
Like, but can you hire me? I'd like to go try.
Bring it.
So it's one of those things. We've all been doing this so long that we're all realist about how hard it is, yet we're still all optimist about making it better, right?
Sure.
So I'm going to say a little bit about myself. I'm the CEO of the Health Plan Association in Texas. We represent all the commercial health insurance companies, the Medicare plans, and all the Medicaid plans. So I see things from a vast array of how these things are hitting each part of the market, and it is very different. Mm-hmm. I also come at this that I'm a registered nurse. Before I got into healthcare policy, I was a labor and delivery nurse, and I came to this because I saw so many C-sections and inappropriate early deliveries and so many babies going to the NICU and so many young moms not getting prenatal care that, and all this money going into it, that it just made no sense to me. Something had to happen. So I started this journey of getting into this. And now it's like 15, 20 years later, we're starting to see this change happen, right? So I'm probably going to echo a lot of the two things you've heard here on my three things. One, I think another speaker said this, you don't get quality unless you start measuring it. Well, you don't get quality until you start measuring it and you start paying for it. Everything in healthcare is about money. It really is. You're not going to see change unless the dollars are really, that's what they're buying, is the quality piece. And what we are seeing in Texas and across the nation is a huge move to value-based purchasing. So that's those alternative payment models. They're paying for quality, moving away from quantity, moving away from fee-for-service. Mm-hmm. But, I think one thing I've found on this is a very popular term. Everyone wants to do it. It seems to be very hard to accomplish, right? So, this is where it gets really tough is making it happen. And, we've had our first layer of providers who were ready for it. Then now you're starting to have the, providers that it's a much more difficult task, and it's hard, They're providing care all day long, they're busy, it takes huge amounts of investment, you don't know if you're gonna get any return on it, and someone's asking you to completely change the way you practice, do all these things differently, and you're not sure if you're gonna get paid for it and how it's gonna work out. So, moving to value-based purchasing is a difficult process, but we're already seeing it work in Texas. And that's how the Medicaid plans in Texas are paid. 3% of their premiums are at risk for quality. They're measured on quality, the quality's reported. They then in turn turn to the providers and contract with them based on that same quality, those same quality metrics, whether it's reducing readmissions or ER visits or improving diabetes testing. The other part I've really seen with moving to value, and then you talked about another state going back to fee for service. It is so hard to move away from widget counting to thinking about things in outcomes. It is just so hard. I watched it with the 1115 waiver here in Texas, where it was a supplemental program. The very first days of it, they wanted to count the number of people getting served, right? They wanted to count how many people came in, how many of this, not did this create an impact or an outcome that improved overall health, right? So that, and I'm watching that battle happen all the time, even with people who really believe in moving to outcomes. Then the other piece of this is social determinants of health. We have to stop thinking in health insurance with all of healthcare that it's just healthcare. Acute care, healthcare, traditional, hospital, doctor's visits, drugs, those are all still very, very important. But what the health plans have been finding, it's all those other things that really matter too. Whether someone has housing, whether someone has someone to hold their hand through a difficult process, whether someone's getting all that education that they need, what their investments in public health. So social determinants of health are a huge component that we really need to start thinking about in terms of health coverage and Medicaid and how this works, because it doesn't fit into that traditional system.
Mm-hmm. Well, that's, these are all really important points. That one innovation thing, is there anything that maybe we didn't talk about in this whole meeting so far that's been sort of in the back of your mind saying, why don't we do this? I mean, Bernie Sanders phenomenon, right? We're all going to have a single payer. The politics for that isn't really apparent. But we could have an all payer where we simplify the administrative infrastructure for everybody has a sort of consistent payment model instead of hundreds of different ways for doctors and hospitals to try to juggle between different companies and different payers. We could think about that. We heard a kind of a crazy notion, but maybe not so crazy, was since the VA negotiates for drug prices, it's the only federal agency that does that, and they actually have a formulary. Now, all the drugs in the universe are actually on their formulary, but in the VA, if you have to try what's in the actual formulary, or the negotiated formulary, and if that drug works, then you're fine. If it doesn't, you have an allergic reaction, or you're not to your clinical goal, then you can move out of the formulary to the other drugs. But they set a barrier for that. Conceivably, you could have the VA could be the PBM for Part D and for the for all the federal programs, for Medicaid and so forth. And I know that there'd be some political hurdles getting there, but there still would be PBMs in the private sector. And I think, so who knows? But I mean, that idea got floated at one of our summits, and who knows? I mean, we do have to think out of the box. Any thoughts coming to you?
This one's never a silver bullet, and everyone's talked about it for a long time, but it is true that it would make a huge impact. It's just final, true, real transparency in healthcare, and real access to the information that patients need in a way that they need it. And that really could make a change. I think when people do think about Amazon and these pieces, I think that is a big component of what they think could happen in the world of innovation.
Especially with high deductible plans, the kind of rise in high deductible plans where the front end is very expensive and you get hit up as a patient, and maybe banked on the fact that you're not going to get sick or no one in your family is going to get sick, and then it happens and then you're shocked that you owe between right now whatever Congress has approved, $6,000 to $13,000, $14,000 for a high deductible plan limits for individual versus family coverage. That didn't really people didn't really think about that. getting hit up with that kind of a front end. And so denying care. So that sort of stuff is in the way as well. We have a lot of things to think through there, and transparency would be very important, especially with people that have those kind of choices to make. Other wild ideas?
I don't know how wild this is, but if you think about just our linear approach to budgeting, and I think you've heard this theme this morning, you know, it can't be that we're talking about education or healthcare. It should be an and conversation. And so it might be wild to consider having those items considered together in line item budgets for state and federal funding. And yet I think that's how kids live. So if I think about, it's not a wild idea, but it's one that is logical to me, and we're having some good early successes in planting and embedding children's health clinics, dental, telehealth visits for behavioral needs in the school, and doing follow-up visits for surgical patients with minor surgery during school, next school day in the clinic, using an app that's encrypted that you can pull down on your phone. So it's sort of connecting the dots, but starting with where there are already points of connection and building around that.
Great. Yeah.
Yeah, so, you know, when you look at the things you've talked about, clearly if society said we want to cover everybody, you would have a plan that covers everybody, right? But we don't have the appetite for that in the country. I mean, that would be the thing to do. Right now you've got, you know, 10, 12% uninsured. That number is going to continue to rise. And so I think if you impose more structure on a system and said, you know, as a society, we're going to cover everybody, this is how you do it, you would cover more people and you'd save money, but that's not going to happen. And so I tend to look at, okay, now what can you do within the confines of the system? And so we've looked at things like, to follow up on your comments, how can you customize care in a way, because right now we tend to treat everybody the same way regarding your condition. So using things like predictive analytics to see who needs more of something and who needs less of something, and how can we customize so that things can become more affordable. So when we looked at readmissions, you get penalized if you have high readmissions, and we looked at readmissions and analyzed what could predict somebody who's going to be at risk for a 30-day readmission. And traditionally we would think that is, so we look at heart failure. It's going to be, you know, did they get their medicines? Did they get good instructions? Did they get a follow-up appointment? Well, a bigger predictor was, did they have multiple addresses in the past year? You know, it puts you down a whole nother pathway of, you know, we're talking about social determinants. And so the resources going into how do you make sure this person has the resources at home to be able to get the care that they need? And so we've looked at, Jamie and I were just talking about our childhood asthma program. So taking information from multiple sources, from prescription medicine fills, from the electronic record, we're able to determine who's at risk for an asthma attack. And so if we find that someone's getting their rescue meds filled at a higher rate than their maintenance meds, that's going to set off a flag. We generate a list, sends it to our providers to say, you know, do some outreach and follow-up, and have been able to show a reduction in ED visits, a reduction in hospital admissions, by using predictive analytics. And I think, you know, you can't afford to do those calls to everybody in your panel, but on the high risk ones you can. And so I think the better we get at becoming more precise, you can get better outcomes, and you can't afford to spread it across the entire population.
Yeah, at one of our, you know, we've had these summits around the country. At one of them we heard, interestingly, that, you know, we know that you know, 5% of the patient population spends just about 50% of the total budget, and we ought to be really honing in on that group of people, because not only they have a lot of problems, they're suffering in many ways, and they're also expensive. So there's got to be some way to intervene there, and that's true even though it's a lower amount of money as a percentage in all the EU nations and the OECD. They also have 5% spending 50%. They're more efficient, so it's a lesser number. But you know, that's one of the issues that has been focused upon, and and the other side of it is that I know this on the cardiology space, that it's really, with the analytics you're talking about, we can pretty well predict who's going to have the crisis, who's going to be, you know, who's going to have the complication while they're an inpatient, and who's going to be back in the next 30 days. And I actually tried to sell to the cardiologists that if you guys, if you men and women would start to go into a bundle thing or take some risk, that the reality is, in the old days, the cardiologists 5, 6, 7 years ago, we were getting $3,500, $4,000 for doing treating a heart attack or a high-risk angina with PCI, with percutaneous, catheter-based therapy. And now it's like the reimbursements have been $800 or $700. But if the cardiologist and the hospital would partner out and say, we're going to identify who these patients are, the most likely, and you were right only 20% of the time, you could return back to the cardiologist $3,500 per procedure. I mean, there's that much to be saved. So there's a lot out there that we need to educate the whole system about the opportunities. And I think it's the 5 to 10, 50, but it's also that whole population of people who are going to be in that 5% next year that you could head off. So there's a lot that could happen. I think you wanted to comment,
Well,
Jamie?
you brought up other countries and utilization and being more efficient. And, there have been about 4 or 5 studies come out in the last few months. I know there was a JAMA one, there might have been a New England Journal, and there was a Healthcare Cost Institute one. And I just, they broke out spending in healthcare. It was almost going back to Dr. Hugh Reinhardt's, it's the price is stupid thing from so long ago. And they showed that ER utilization actually has gone down, but prices have gone up 30%. And so when you looked at healthcare cost over this last, 5, 6, 8, 7 years, we have been making a more efficient healthcare system if you're looking at utilization.
Sure.
And appropriate utilization, we're moving that way, but we're not seeing any gain from it because prices are just killing it, right?
Yeah.
And so it's just taking away any benefit of all these improvements we're seeing, and it's hiding what's happening in the system, and we keep thinking, oh, we've got to, and there are places you need to have, more chronic care. There's a problem with readmissions for individuals who have behavioral health needs and making sure people are getting substance abuse and mental health treatment and social. There's all these things that really can happen.
Yeah.
But at the same time, you are seeing huge improvements in efficiency and utilization. You're watching hospital systems and provider systems make these changes, and you're seeing these things happen, but we're not getting the benefit of it because of prices. And I'm not, I don't know what that solution is, but prices are a problem in the United States.
Well, I think that, that people would go kicking and screaming on that one. And, I know the Texas Medical Association very well here, and, they would, find a lot of reasons to object.
Well, to both of your points, as long as you can pick pieces and optimize that piece, you'll never get ahead of it. My cardiologist friend a few years ago told me that Medicare pays him so little for an office visit now he has to do an echo on everybody that comes in.
Right.
But you're going to figure out how to get the dollar out. But if you become responsible for a population, then you can become more clever and think differently.
And that's the point. And John alluded to it. If we don't have the payment reform, it's not going to happen. You really have to have different payment models. You have to have risk. You have to have capitation. You got to have or bundles or some way to get at a more organized approach to get there. But I hope the folks up in the audience, it's time for your questions. So if you have a burning question, raise your hand, please, and then get the mic. And if somebody else has one, Dee will find you, so put your hand up. Hi.
My name is Bella Kirchner, and I'm the Director of Population Health at Austin Diagnostic Clinic, which is a large multi-specialty clinic here. And so I know you guys are from hospital systems, but and so you're looking at population health and value-based care from those perspectives, but a lot of doing the cost savings and quality starts in primary care offices as well. So, we're lucky in that we're large enough to have invested in population health and have a focus on that, but I know there are a lot of smaller providers' offices in your communities that, 1 or 2 docs, 5 docs, those kinds of things. And so, as you mentioned, it's a big investment and it's a lot of education. It can be very complicated and all those things. So, do you guys have ideas on how to kind of scale this down to those primary care clinics that may be smaller or rural or don't have access to the kind of infrastructure that larger hospital systems or healthcare clinics have?
Well, I mean, I don't, you don't mind me answering a little bit?
Of course.
The health plans really think of primary care docs, OB-GYNs, pediatricians as the quarterbacks of healthcare, right? If you can really help them make the best decisions possible for a patient. It reverberates throughout the entire system. So, and we moved to value-based purchasing. Medicare's the leader, the Medicaid's following, and you have the private health plans coming in behind that. And I think that typically is sort of how you see change happen in the healthcare system. And one of the things I'm seeing Medicaid plans do is giving those provider offices that technology, or putting someone in their office to help them get through that. The other thing I've noticed is almost sort of like a co-op option, where those, and I believe, I can't speak for TMA, I believe TMA, the Texas Medical Association, has been working through this and has a product where they're attempting to almost create that sort of co-op option, where those providers can still independently practice, have an individual office, but is there some way to form a co-op of them to share technology, share that information? But I have to say this is really important. It's really important to have flexibility in a value-based purchasing system. You cannot have one size fits all. Every provider is different. You cannot expect the same thing from all different types of providers. A very sophisticated, large provider group that's seeing hundreds and hundreds of Medicaid patients is different from that rural doctor on his own, out there practicing, and we do need to have some flexibility on the expectation for that.
Yeah, California has gotten to that by having independent practice associations. Virtually every doctor almost everybody, if they're not a concierge doctor, they'll have a fee-for-service practice, but they'll have a significant, half their practice will be through an IPA and capitation. And, there's a little bit of that in Minnesota and some other places, but so a co-op could work as well. But doctors do need to be together and taking some risks together.
So while you can have flexibility on the payment piece, I think the part that really helps is to align the goals and outcomes.
Okay.
So, you don't have different expectations, and this is really where you could see state policy, leadership coming in and saying, what are the goals, let's use Texas, what are the goals we want to see for healthcare in Texas? Let's align those, whether it's through the hospital systems, through the health plans, through these pieces, and then that way a physician knows what it is that, here's the goal outcome measure that's happening, and then there are other ways to get those types of information into those offices.
Yeah. Cynthia, do you have a burning question?
I do, and I really appreciate all the conversation that's going on here, and the talk about prevention and having fewer moms show up in which their babies would need to go into the NICU, talking about predictive analytics to keep folks from re-entering. How, as both funders and providers, are you really thinking about some of these longer-term demographic changes? In Texas, we know that our disadvantaged population is our population that's growing the fastest. The demand on your systems are going to be greater, especially with chronic diseases and other sorts of things, and they will have negative health behaviors in addition to negative health outcomes. Is this something that you guys are looking at in the future? It's not, you don't need very strong predictive models to actually see what's coming down the pike. Can you talk a little bit about how far out you're looking?
Okay, sure. I'll go first. And so you're describing is what we see, we're experiencing it today, and that is it's access, right? And so in Dallas, there are about 1 million people who are either uninsured or on Medicaid, about 600,000 uninsured, and that population is growing. So a big part of our work is how can we, with the funds that we have available, how can we stretch those? Looking at the delivery system, what do we need to do to try to accommodate the demand that's out there? And so some of it is that customizing care, doing more for some and less for others. Not everybody needs, the every 3-month visit or every 4-month visit. Even simple things, So customizing care is one piece, but then looking at the delivery system and seeing, we call it democratizing knowledge or democratizing care. How can you spread that out of the system? So, for instance, we used to have people that were uninsured would sit in the hospital for 4 to 6 weeks to get IV antibiotics for a complicated infection. Now we've taught those people how to deliver their own IV antibiotics at home. They don't have a home health nurse because they're uninsured. But now they can learn how to do it themselves, and they do it at home. It's safer. We've done it to over 1,500 patients now, If they forget how to do it, they can pull out their smartphone and scan the code on the back of the antibiotic bag, and it takes them to a YouTube video that walks them step by step through how to do it. And so things like that, using our specialists, there's great demand on our specialists. So we've moved to a model we've now piloted of e-consults, our primary care docs who share the same electronic health record with our specialists. That's important to be able to share information. Now, instead of having a patient make another appointment, make another day, miss work, a lot of our patients, you miss work, you don't get paid, transportation's an issue. The primary care doc now can email a consult to the GI specialist. They can pull up the medical record, answer that consult. We've learned that about 70% of consults for that specialty can be handled in that fashion. And so now we're looking at, okay, what other specialties can we do that? We're doing derm, pictures of derm, skin lesions, things like that.
I'm glad you brought that up. You know, Kaiser Permanente, very, very large.
We went to Kaiser and stole that from them.
Yeah, Kaiser Permanente has, you know, reduced their outpatient visit frequency by 50%. Wow. And it's going up. And they have better results with chronic disease. They have happier patients.
Right.
Okay, what did they have to do to get there? They had to give the beleaguered physicians and nurses and clinicians some time during the day to answer the volume of emails. They didn't say, after work tonight, why don't you answer 100 emails? Wouldn't that be fun? No, what they do is they give them a couple hours during the day. They figure out what the allocation of time is, and they actually give them that time to answer the emails, and they have to answer them. So the system really works. Now, you know, we could add visual to that. We could be doing the equivalent of FaceTime so that you're looking at the patient and you can see for yourself if you think they're heading for distress and it's time to get them in or get them to the ER, ED or whatever. So I think there are technology things that we're kind of slow to apply.
But you know why Kaiser can do that and we can do that is because they're not, every visit is not income for them. They're a capitated health system and a provider. And so if they can do it in a cheaper way, that's better for them too. If you're driven by the encounter, you have to have the office visit. I'm not going to do that electronic consult.
Yeah,
I'm going to say send them into the office.
That's why the payment models have to change or you don't get there. So if you don't have the payment model change, no one's going to do this stuff. They're not going to say, for example, we'll pay for the transportation to get you in for this visit. I'm on an FDA panel for adherence, and we've had 5 wonderful years working on it. We've monitored 0 progress. 50% of the people on life-saving cardiovascular medicines aren't taking them. 60% when it's talking about antiplatelet drugs. And we've tried everything. Finally, this little company in New York City called Wellth, W-E-L-L-T-H, has come up with a model that because we've been scanning the environment looking for anything that we can measure works. And this little company has decided they have an app where every day the patient gets up and they put the pills they're supposed to take in their hand and they take a picture of it. And if they do that, that's worth $3. Okay, and if you were a real wealthy person that just didn't want to take your meds, this wouldn't work for you. But for the high-risk people that we're really trying to get to, the $100 a month makes a difference. And they're doing it. And then after they found that after 3 months of that, this $100 a month bonus, they're just into the habit. They realize they're really feeling a little bit better. They realize that they didn't get allergic, and they just go ahead and do it, and the adherence improves. So maybe this is one model that works for at least some people of middle to lower income. Who knows? But we got to figure something out with a whole lot of those things. And if you don't have the payment model to incentivize that or to do the things that the social determining stuff, it ain't really going to happen. And so that's one of our dilemmas with. We can't see how fee-for-service gets where we want to go with value, right, John?
We have one more question here.
Yeah.
Hello again. So how are you all addressing transparency and cost? If you look at the healthcare dollar, physician fees are less than 10% of healthcare expenditures. And if you look at what's happening in healthcare over the last 20 years, hospital administrators and their salaries have soared exponentially while physician salaries stay fairly stable. The number of private practice physicians has dropped as hospitals buy them up, and the cost of being seen by a hospital-owned clinic is more than seeing a person in a private office because you add facility fees. And then you mentioned the pharmacy benefit managers who sound like a great idea, but they have tremendous profits, and that is not passed on to the consumer. The cost for me going to get my prescription doesn't change because there was a pharmacy benefit manager. So how do you address the transparency so that I, as a consumer of healthcare, know what it is I'm getting, know what I'm paying for, and then can choose whether I want to go to your office or their office for my healthcare needs?
I'll be glad to jump into that fray. The transparency, I don't think we've done a good job of it in our system at all. I'll tell you what, we've done a couple of things that I think are meaningful on the pediatric side, and one of them has been to make a concerted, educated decision not to have hospital-based clinics because of the additional facility fee attached to it. We just have morally believe it is not the right approach. Now, it has had a deleterious impact to the bottom line in the short term, but it just depends on the time horizon, and we're trying to play a longer game. In terms of, physician payment, all I can tell you is I don't have a solution for that other than to acknowledge that over 50% of physicians are now employed. I think that goes back to some of the waste. If you think about, the administrative, all the blah, 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 it's such a burden that I don't think the independent practitioner can manage that burden. So I think all of us collectively own the solution around that one. But I think the transparency challenge is a really fair one, and I think we're more easily able to do that on an MRI or a CT, but I'm not sure that really gets to the heart of what people are really asking for, like who's going to read that CT? Is it a pediatric neuroradiologist if I'm worried about my kid's head, or is it just a generic radiologist? I think there are a couple more layers in transparency that we're going to have to deal with in order to really make it meaningful.
But you don't think that as physicians become employed by the hospital groups, if there's greater efficiency in that happening, then costs should fall, not lower. It shouldn't become, so when I practiced in a private practice for 10 years, the cost to see me was less than the exact same visit when I became part of the hospital group. And that's not fair to the patient, and that's not saving money. So
Yeah, no, I think that's, point well taken. Well, I'll tell you why, because that independent physician practice is now onboarded into a large corporation, and so all the fees, the overhead, the blah, 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 is assigned and allocated back to that practice. And is it fair? Unlikely that it's fair. Is it, what we're dealing with sort of at a broader level? Yes. And so I think it's our path forward. But, I think it's an overwhelmingly complex issue. I think we're much better positioned to give transparent data around bits and bytes and episodes than we are to kind of array the whole of your healthcare, world and tell you as an individual, how do you get value at this place versus that place?
Well, I'm going to give you an example of it's not going to be physician transparency, although, when we look at this, health insurance companies have calculators, right? So you get on, you can calculate how much your copay, what the cost is going to be if you have time in advance to go through that. If you're dealing with a high deductible plan, paying out of pocket, uninsured, you don't have that information. I call it point of sale information. So for a long time, we've gone through average cost, or what is the health plan paying, but just what is the point of sale information, just like you would get with any other item in the market today, right? When you're dealing with a provider. And the best example I have in Texas is, it's a Texas problem, is freestanding ERs. And it is, and here's the deal. It's a very interesting example how people want convenience. They just want to be seen right now. They want to walk in. They don't want to have to deal with an appointment. They don't have to wait 3 weeks. They just want to see someone. There's, in a 4-year time period, there's over 300 of them now in the state of Texas. More than 50% of them, more than 50% of the freestanding ERs in the United States are now in Texas. That's, where we have like 600, 700, maybe 800 hospitals. We've gotten, 300 freestanding ERs in a very short time period. And, I think the employment retirement system just put out some numbers last week where they're all out of network. So everyone who goes and see them has huge out-of-pocket cost.
Sure.
And they're charging the provider fee, a facility fee now, which is confusing, and an observation fee of $2,000 an hour for every hour you've been seeing. So people are popping out with $6,000, $10,000
Yeah.
bills for a cough or a flu shot.
They must love their copay.
And here's the deal, you know, I've been dealing with this. This has been one of our biggest issues that we've been trying to deal with for the last 2 or 3 years. And you know, it's not to say that there wasn't a marketplace for them or people didn't want more convenient care, but one, how is it that we've expanded the most expensive version of care and made it the most accessible version of care instead of the other way around? And then two, the biggest thing that we get is people are going in and they're asking, are you an urgent care facility? Are you a freestanding ER? You know, what are you? What is this going to cost? Are you in my health plans network? And they're told, don't worry, your costs are covered. We accept all insurance. And they're not in any single health plan's insurance company. So people are asking, they want to know, but they feel like they've been told, oh, they accept my health insurance. They're just going to ask me for $50 to $100 today. And then 2 or 3 weeks later, they get a $5,000 to $10,000 bill.
Sure.
And so, you know, it's our biggest cost driver in Texas
Yeah.
at this point. And so it's a good example of just how much a lack of transparency is a problem in healthcare, plus the desire and need for convenience and for healthcare to change for consumers.
Yeah. Well, CVS and Aetna are sort of banking on the fact that they can we can use advanced practice nurses right there at the drugstore in your neighborhood, and you can go in and get seen really quick and in and out, and they'll guarantee that, and that's going to work for most things. Actually, just a telemedicine visit. So the millennials, I'm really clear, would really like to just have a quick, you know, telemedicine visit to find out whether they really need to take off work today and take the kid down to the pediatrician, or whether just to get at least an opinion, the first level. So there's a whole lot of opportunity there to kind of offset that. I think there's some disruptive innovations that can get those freestanding emergency rooms out of business.
Okay,
in the
I
near
think
future.
I'm sorry, one more time for one more question. We're going to get in before we transition one more time.
Okay.
Hi, my name is Robin Payson. I'm the Executive Director of Communities for Recovery. We provide peer-based recovery supports and services to individuals in recovery from substance use or substance use and mental illness. Here's my question. We know that substance use disorders and mental health disorders are some of the consequences of high adverse childhood experience scores, and studies show that. And we also know that substance use and mental health disorders drive some of the highest drivers for healthcare costs. What are some of your innovative ideas? And I agree about the payment, changing the payments model, but what are some of your ideas about how to better address those issues?
Well, I mean, you know, we have the Meadows Foundation and the Hogg Foundation. We have some really amazing behavioral health foundations in Texas that have been leading the way on this. And, you know, two things that I have really heard that are really innovative in this, you know, is one, the integration of behavioral health and acute care services, and no longer siloing those two things out. And then the second part is that further part of that integration is that having, you know, all providers be able to provide those services. You know, you don't have to go into a psychiatrist, your primary care doctor becoming more comfortable and learning, you know, and practicing and providing those same services. Otherwise, we just don't have the access that we need. The access we need to meet. Okay, good. To meet those services.
Very good. So any closing points that you want to make? Oh, we're at just about the end of our time. Any closing points things we didn't say that you really wanted to
I think the theme, value-based purchasing, right?
All right. So let's thank Frederick and Susie and Jamie for a fantastic job.